what can we say about sexual health and general health?
Well,
And
I
by the way,
think,
let me phrase my question a little bit better. What I mean by that is overall well-being as a function of sexual health. We've already established the causality in the other direction, meaning when your metabolic health is poor and your vascular health is poor, it can impact sexual health. But um, what I'm saying is even independent of that, if a person is otherwise healthy physically, but still having sexual dysfunction, how does that translate into the rest of their life?
well, so I think there's a couple ways to look at this. One thing is most of the research, I guess we're talking about women today.
Yes, yes.
Most of the research is association research, right?
Yeah,
So it's sometimes a little hard to tell. I think you understand the
of
difference
course.
between really risk factor and cause and effect. So we know which lifestyle and health factors seem to be associated with better sexual function, better satisfaction, better sexual activity, right? And most of the research is actually in desire when it comes to that. Like
Hmm.
we know that, like, for example, I'll give you a few examples. In women, there's interesting research that being resilient, having a positive attitude, for women, especially as they get older, having a partner, right? Being connected socially, having support, normal BMI. The funny one is Mediterranean diet, actually. It probably has to do with overall health and well-being and the
Yeah.
other benefits. All of those things are associated with good sexual function, right? And whether people who do those things preserve their sexual function or those things preserve sexual function is still, it's association,
Yeah.
right? I sort of think it doesn't matter. You want to, they're both are good, right? Where it matters as a motivator is that validating the importance of sexual function to quality of life, is critical for people feeling that they have permission. Like that's a good reason for me, right?
Hmm.
Because sometimes it's like an afterthought, like, oh, okay, it's okay, I could prevent heart disease, but do I have to preserve my sexual function? That's a little indulgent, right? Why should I go to the gym just to have better sexual function? My kids need me to help them with their homework. But if it's like, okay, I can't have heart disease, I have to go to the gym. So I think part of it is validating that for people that probably there's strong association. And then on the other hand, we know what the heavy hitters are in terms of overall sexual function and biological medical conditions and psychiatric disorders, right? I'm not sure if this is exactly what you asked me, but it's a point that I think is important to make. And we could go back and clarify if you
Yeah,
wanted to
yeah.
hear anything different. So the heavy hitters, we could talk about categories, right? There's what we've already been talking about. There is associative data that metabolic syndrome in women, obesity, particularly interestingly, hypertriglyceridemia, which probably makes sense to you, right?
Mhm.
And then coronary artery disease and diabetes. But what's interesting about the last two is that the condition itself isn't as clearly correlated as the psychological adaptation or relationship to the disorder is for women. So for example, if someone had a heart attack or has heart disease and they're female, it's more about how they see themselves and their interest or enthusiasm in becoming re-engaged with activity than clearly the severity of cardiac disease. And that might just be we don't
Wow.
have good research,
Hmm.
or it might be different in women. And same thing is true with diabetes. Like in men, it's clear, like the higher A1C, the more sexual dysfunction, neurovascular disease, et cetera. But in women, it's more about the impact of diabetes that it's so far in the research. Are they depressed because they have diabetes?
Yep.
Is it impacting, like they don't like wearing the monitor, so they're embarrassed to have sex, or like, things like that, or their feet are numb and it just makes them negative, rather than their blood sugar control. But I think that part of the problem is we don't have as good research. And then there's the whole bucket of genital urinary symptoms, menopausal symptoms, and cancer. We haven't even talked about cancer yet. Breast cancer, gynecologic cancer, cervical and urinary cancer, ovarian cancer. So those are the categories, all those things I just mentioned, that are associated with lower sexual function and sexual problems in women. And then there's the whole bucket of depression, anxiety, and their treatments, right? That also, and clearly interacts with sexual function in women and can be problematic.
And I'm kind of curious about both of those in both directions. So for example, like if you take two women who are identical in all ways, but one of them is sexually active and sexually healthy, and the other one is having sexual dysfunction for whatever reason. And let's assume it's not a physiologic reason. So let's assume it is a supratentorial reason. And as a result of that, she's just not sexually active. Do we have a sense of their quality of life, their well-being as a result of that? In other words, what I'm really trying to understand is how
Yeah, I
important
understand the
is
question.
sexual health for overall well-being, and in
So there's
particular, in
a
this case, for women?
there's a kind of a collection of different buckets of research looking at this. Probably the strongest and most consistent research comes out of the desire literature and looking at the impact of hypoactive sexual desire disorder, which is more like a diagnosable condition, or distressing low desire on overall quality of life. And there's, I could quote you studies, but there's a number of well done both survey studies, which are like in the community and population studies, and clinical data studies collected in clinical settings, suggesting that there's a strong correlation with impaired desire and overall quality of life, right?
Mm-hmm.
The problem I think with this research is, the dichotomy or distinction you're making, that it's purely supertentorial or psychological, relational, lifestyle, is sometimes so hard to tease
I'm
out,
sure.
right?
Yeah.
Right? Because there's like no one person has like zero biology impacting sexual function. But I will say something that does support that point of view. What Practically speaking, you look at if you're a clinician, let's say, or someone comes to you, you look at the biology, you look at the psychological factors. Maybe it's sometimes even past sexual function or sexual trauma or religious upbringing, or how they were, they saw themselves as a sexual being from the time they were young. As a clinician, a physician, I ask those questions. Then you look at the relationship, and how that is, or the culture. And then you look at the things that you think are contributing and those that are amenable to intervention. And you do get to the idea sometimes that it is the psychology, right? You can reach that. But you want to be careful not to assume that you've thought about everything in their biology until you have, right? But that said, you were asking me the condition of someone who has like a psychological sexual dysfunction, and what is the level of distress like? When people identify it and they want it to be different, it's extremely distressing and quite impairing to quality of life. And it can be a mirror for very distressing feelings. There are studies that look at the level of distress and the qualities, and they show things like, if, for example, loss of sexual desire, despairing, hopeless, feel old, feel ugly, don't feel connected, feel sad, feel hurt, there's a whole collection of emotions associated with it. And typically in this research, they also look at discrepancy. There's been some, and when they look at the discrepancy between, for example, a clinician's perspective or perception and the patient's, when they're asked by like someone else, like an independent reviewer, usually it's way underestimated how distressing or impairing it is to quality of life. We don't do a great job of understanding this, and it's part of it is legitimizing this, right? And that's what we're doing here today, is like really legitimizing, like, this is a real thing for you. It affects your quality of life. It's okay to tell me, right? And it's okay to want this to be different. And when women are given that permission, either because they're being interviewed in a study or somewhere in a doctor's office, or they embrace it because it is something that they're feeling. They're feeling impaired quality of life. I think that's what you're sort of getting at.
Yeah.
And this is worth like emphasizing, giving this audience permission to understand that you can seek assistance or understanding or even treatment for these things, for different sexual dysfunctions. And we could get into defining them a little more specifically, soon. That's good, right? It's not something you should put as like an afterthought in your life, right? Because first of all, it's good for quality of life. It's good for your relationship. And there's also some, I don't know if you quite asked me this, but there is some research supporting the idea that it improves overall health, right?
Again,
so
that's
women,
not a stretch, right? I mean, whether or not that turns out to be true, we would only know with more rigorous study. But there's plausibility to that based on other things that we understand about the relationship between hypercortisolemia, HPA dysfunction, stress, all sorts of things that we know do directly impact physical health. So, my way of thinking about these things is they may or may not impact the length of your life, but the quality of your life is at least as important, if not more important. And it's very hard to argue it doesn't impact the quality of life, especially if, as you say, it is being perceived that way. So I'm going to preface my next question with an assertion, which is, just because evolution didn't care about something doesn't mean we shouldn't. And the example I would use is atherosclerosis. So evolution had no interest in preventing atherosclerosis. If it did, it would have got rid of ApoB hundreds of thousands of years ago, because we didn't need it really we would have got rid of it in the last 1,000 years, I think. And we wouldn't have atherosclerosis today. But given that it didn't interfere with our reproductive fitness, it's of no concern to Darwin. That said, now that we can live longer, we have every reason to care about it, and we've taken great pains to reduce our risk of dying from it. Okay, so put that aside for a moment as I ask a very naive, potentially, question, but one that I've often thought about, which is, do women have it harder when it comes to sexual health because evolution didn't necessarily care about their sexual function post-childbearing years, whereas in theory, evolution might care if men could reproduce through the length of their life?
Yeah, I mean, absolutely. Absolutely. This is a really important topic and area for discussion. So let me start with a point that I make often. I mean, women who are perimenopausal, menopausal, and postmenopausal aren't sick, right?
Yep.
And so sometimes people talk about it, and when you have postmenopausal vulvovaginal atrophy, right? Like, that's a horrible term. Talk about evolutionary terms that make people feel bad.
Right. It needs a whole PR firm to come in and just come up with better terminology here.
As an aside, I think you've heard this terminology, is that the North American Menopause Society and the International Society for the Study of Women's Sexual Health, I guess it's almost a decade ago at this point, and I was involved with this process. We got together and had a whole panel on what to do about this name, vulvovaginal atrophy, for a whole variety of reasons. And it concluded that it is what happens, things atrophy, but that's not like what we want women to think about. So we came up with the terminology genital urinary syndrome of menopause, right? So vulvovaginal atrophy can lead to genital urinary symptoms during and after menopause, and the syndrome of menopause. So it took away the disease state. It's not really a illness, right? Yep. And it's a syndrome, which could be thought about in many other ways. I mean, happiness is a syndrome, right? And so we were really trying to neutralize it. I don't know how well it stuck, but it does speak to this idea. First of all, a few concepts. One is, when people talk about symptoms or treatments, are we talking about a disease, right? I guess when we're talking about atherosclerosis and aging, we're talking about a disease. So on the one hand, you could put them as parallels, right? There's hormonal changes. The ovary stops making things. The brain does other things to the sex steroid hormones. Testosterone declines in both ovarian and adrenal production, et cetera. And we have physiologic changes which lead to aging, lead to decreased sexual function, and even complete loss of good sexual function. Pain doesn't allow women to, engage in quality of life improving sexual activities, relationship building activities. So evolution has not been kind to women in a whole collection of ways. I think that's what you're asking me. And although women aren't sick, our position in the field, and certainly mine, is that we have the skills, the tools, and the sophistication to manage it and to reverse it and to have a very different outcome than evolution would command, right? So I'll speak, not too personally, but I'm a midlife woman. I'm not ready to turn in the towel. And I can tell you that most of my colleagues and friends and family members, have the same attitude. And so, the challenge in the area is, first of all, not medicalizing this too much, right? And making someone feel sick, or you give them things that make them sicker. And to balance that, for lack of a better word, lethality therapy balanced to the point where you're optimizing without giving people other problems, right? Like you give a hormone, you don't want to give breast cancer or endometrial cancer, right? Or you give estrogen, you don't want to cause cardiac disease. And so that's the work that we do in this field, is learning how to trick Mother Nature or evolution safely, but optimize all of these things: sexual function, quality of life, longevity, even.